Alrighty, we are live.
Good morning and thank you. Welcome to the Public Health and Minority Health Disparities Subcommittee. We have a number of bills today. For the good of the order, the bill order we're going to be working on today is HB 504, followed by HB 716, HB 726, HB 283, HB 626, and HB 1148. We're just letting in our stakeholders right now. So we are going to go ahead and start with House Bill 504, which is the Maryland Developmental Disabilities Council establishment. Erin Hopwood, can you walk us through the bill and the amendments?
Yes, the bill establishes the Maryland Developmental Disabilities Council as an independent unit of state government with the authority to conduct and support advocacy, systems change, and capacity building efforts to promote inclusive communities and equity and services for individuals with disabilities in the state. The council would also research best practices and provide related training and technical assistance to communities in the state and inform state and local leaders about disability issues. There were no amendments offered at the bill hearing.
Is there anyone who wants to be heard on this bill? All right, and this bill already passed the Senate, is that correct?
Correct. It passed the Senate 45-0.
All right, do I have a motion on the bill?
Move the bill as amended.
I have a hand up from Delegate Riley.
There's no amendment.
Go ahead, Delegate Riley. Unmute. You just need to unmute.
Sorry, my internet was a little slow getting on. Can you tell me what bill we're on?
We are on the first bill, which is House Bill 504. It is the Maryland Developmental Disabilities Council establishment. There are no amendments and we have a motion to move the bill. Did we have a second?
Second. I could, go ahead.
All right, and do you have any questions or concerns, Delegate Riley?
Do not.
All right, thank you so much. All in favor of House Bill 504, say aye. Any opposed? All right, that bill passes subcommittee unanimously. Thank you. We're going to go ahead and move to House Bill 716. House Bill 716 is Managed Care Organizations Acknowledgement of Responsibility for Payment of a Retroactive Denial Repeal of Applicability. Erin, if you could walk us through the bill, and this one also has amendments. So if you can walk us through the bill and the amendments.
Sure. The bill as introduced provides that a managed care organization that retroactively denies reimbursement to a healthcare provider is not required to provide certain information regarding the entity acknowledging responsibility for payment of the denied claim. The bill sponsor, Delegate Gazzoni, has offered an amendment which has been provided, and this amendment would conform the bill to its cross file, which has passed Senate Finance. If you look on page 2 of the amendment, the new language in paragraph 2 pretty much states what the bill does now, provides that if a retroactive denial of reimbursement is the result of coordination of benefits, a written statement provided by a managed care organization to a healthcare provider in accordance with current state law shall include the name and address of the entity identified by the managed care organization as responsible for payment of the claim.
Thank you. Can I have a motion on the amendments?
Move the amendments.
Second.
All right, any discussion on the amendments? All in favor, say aye. Aye.
Aye.
Anyone opposed? Go ahead and raise your hand. All right, on the bill as amended, can I have a motion?
The bill as amended.
Do I have a second?
Second.
Second.
Thank you so much. On the bill as amended, any discussion? All in favor, say aye. Aye.
Aye.
Any opposed? All right, thank you so much. House Bill 716 passes unanimously from the subcommittee. All right, we're going to move to House Bill 726. That's Maryland Medicaid Assistance Program Autism Waiver Military Families. Erin, if you can walk us through the bill.
The bill requires that a child on the registry for the autism waiver remain on the registry if the child's family relocates out of state for military service, and provides that if a child on the registry for the waiver becomes eligible for services while the child's family is out of state for military service, that the child shall be eligible for services through the waiver if the family relocates to the state. There were no amendments offered at the bill hearing.
And this bill, the cross-file has also passed the Senate, I believe.
Correct.
All right, can I have a motion on the bill?
I'm sorry, bill number again, please.
It's House Bill 726.
Thank you.
Yeah, there were no amendments on this bill.
Make a motion to move the bill.
Second.
Thank you. The bill has been moved and seconded. Any discussion? All right, all in favor, say aye. Aye. Anyone opposed? All right, House Bill 726 passes unanimously from subcommittee. Thank you so much. So we are going to now move to House Bill 283 for discussion. We're not voting this bill today, but we did want to get our questions answered, and this is the opportunity. It is 11:50 now. So I'm going to make sure that we have 20 minutes to discuss this bill. And this is House Bill 283, Maryland Medical Assistance Program, Gender Affirming Treatment. And Erin, if you can walk us through the bill.
This bill would require Medicaid beginning January 1st, 2024 to provide coverage for gender affirming treatment. The bill expresses the intent of the General Assembly that Medicaid provide gender affirming treatment to all Medicaid recipients for whom gender affirming treatment is medically necessary, including transgender, non-binary, intersex, two-spirit, and other gender diverse individuals.
Thank you. And I see a hand from Delegate Hutchinson. Go ahead, Delegate.
Thank you, Madam Chair. So one of my confusions about this, and I've had discussions with the bill sponsor. I had a great meeting with Margot and Sam and Alex, is the question of age and parental consent. And I've been told by all the other sponsors and stakeholders that it has an age restriction of 18 and it does have parental consent. But as I read the bill, I don't see that in there anywhere. And I need some help understanding that.
Ms. Pine,
gender affirming care is medical care, and in Maryland, medical care requires parental consent until a person is 18. When they're 18, they can consent for themselves. Until then, parental consent is required. There are certain exceptions for that, such as sexual health care, that this does not fall into that category. And so therefore, this is medical care, which is already covered under Maryland state law.
And Dr. Pine, I apologize. I should have introduced you. So for the good of the body, we have Dr. Elise Pine, who's here from Chase Brexton Healthcare. And we also have Dr. Renata Sanders, who is the Director of Pediatric and Adolescent Services for Johns Hopkins Center for Transgender and Gender Expansive Health, here to help answer some of our questions.
Okay, Madam Chair, though, that was only half the question was answered there. The other was whether surgery could be done. Is there a requirement that the age has to be 18 or older in order for surgery to be done?
Delegate Kaiser, you unmuted. Go ahead.
Thank you, Madam Chair, and thank you, Delegate Hutchinson. And I believe the pediatrician might be able to give a firmer answer. From my understanding of the thousands of adolescents who've received gender affirming care across the country, the number who receive surgery might be 20 or 30, well under 1%. We're expecting this bill is only going to add 25 new people a year and not necessarily adolescents to getting this coverage. So it would be, 0.001 person. But I think to answer the concern, the situations under which it happens are so incredibly rare and so unusual, special circumstances circumstances and reminding you of all the psychological and medical and all the steps that need to happen. I think an example was provided. A few of us were talking yesterday in committee. If someone is doing some kind of self-harm, it might be an unusual situation that it might be determined that the surgery is best for their physical and mental health. And the pediatrician might want to back me up, but it's very rare situations.
And
Madam-
Dr. Arrington Sanders, go ahead. Did you
Yes,
have-
I can
have more to add?
respond to that. I can respond to that. First, let me just say that surgery is only recommended for a transgender adolescent if they meet all the criteria for the WPATH standards, and the patient, their parents, and a qualified medical professional all agree that the care is necessary. And as the prior speaker spoke, it is very, very rare that this should occur. At Johns Hopkins, at our institution, patients are not referred for surgery until after at least 12 months of receiving gender-affirming care, that they actually have been evaluated and treated by a licensed medical clinician, a practitioner, a psychologist or psychiatrist or mental health therapist, as well as in our institution, we do not do surgery under 18 years old. The age of surgery is insurance dependent across the country. Our minimal age of referral is at 17 years old. And this really allows for adolescents to actually have the capacity to provide consent and assent for surgery with their parental consent in addition to that. When older adolescents are referred for surgery, as the prior speaker just spoke, it is very rare.
Madam Chair,
Go ahead.
thank you so much for that that great information. I just want to share too with the subcommittee. I reached out to Care First and I received a copy of their gender affirming care policy. And Care First does require that in order for surgery to be performed, that the individual is 18 years or older. I just thought I'd share that with the group.
Thank you very much. Thank you, Delegate. Are there other questions from the members? Delegate Riley.
Yes, thank you, Madam Chair. Yeah, so I just want to confirm, so I have a clear understanding. So adolescents can qualify to have surgery if they have, I guess, some type of behavioral, mental health situation going on. And then it's determined medically necessary. But then at that point, they do have to have parental consent. If it's under mental health, do they always have to have parent consent? Is that what I heard? Even with that diagnosis?
Parental consent is always required for an adolescent to receive surgery, any surgery,
Gotcha.
not just this
Right.
particular surgery, but any surgery in the state of Maryland. Parental consent. This is considered elective surgery. So they will not allow for adolescents to receive the surgery without parental consent.
Okay, thank you very much. Appreciate it.
Delegate Kaiser.
Thank you, Madam Chair. And I just want to, in responding to Delegate Riley, we have a lot of issues with parental consent, and a lot of times the issue comes up. And here's a case where we are saying that all of this is happening with parental consent. And if you want parents to be in control, and if you want parents to have certain policies, then this is exactly the kind of bill you should support, because parents have to be included, and parents are supporting their children, they are loving their children, and they are allowing them to have some of these procedures. And obviously, mostly just when it's adolescents, mostly just puberty blockers, but parents are involved the whole time. Thank you.
Thank you, Delegate Kaiser. Delegate Hill, and then Delegate Hill.
All right, thank you. First of all, I wanted to say hello to Dr. Arrington Sanders. It's good to see you. And I just thought it might be helpful if you could give an example I mean, everyone seems to think that gender is white and black, right? It's either or, and perhaps you can give an example of a case where there is gender confusion at birth, or there have been other things that happen, XXY or what have you, where some of our members could better understand when it would be appropriate, why a parent might agree to the rare circumstance of any kind of surgery under the age of 18.
Well, thank you, Delegate Hill, for asking that question. I think that first, it's really important. I always describe the gender affirming care that we provide as patient first and family centered. In that, I think there's a big misconception that there is a lot of gender affirming care that's occurring secretive, without parental involvement. And we really work to engage the parents in the conversation and in the agreement and the approach in what we're providing. And so I'd like to just tell you a little story about a patient of mine who sort of exemplifies of this and what you're describing. And I'll call her Becky, and this is her pseudonym. This is not her actual name. Becky came to me when she was 8 years old with both parents. She had long blonde hair and blue eyes, and she liked playing with dolls, and she liked pink and purple, and her best friend was Raquel. She was given a name as Brian. But at 5 years old, she told her parents that she identified as a girl. And the parents had really supported this and supported her transition. And so in that first visit, Becky and her parents, we sat down for 2 hours and we went through what gender affirming care was. And at that age, it's really around providing appropriate psychological support, making sure that Becky and her parents have the skills and the ability to address all of her needs, and linking them to resources. And so that's what social affirmation is. And once Becky started to get older, when she became 10 years old, she described some anxiety and actually started to do poorly in school. Because her body had started to change, and also because her peers' bodies had started to change. And so the parents had talked at that time about how to put a pause on puberty because it was causing her a lot of anxiety. And that's what pubertal blockers do. So pubertal blockers are reversible. They're like pumping the brakes in a car, right? You pump the brakes, you slow down. When you release or let off the brakes, puberty restarts. They're safe, effective. We've been using them for decades. So Becky went on pubertal blockers for a very short time. And then later on, continued to express that she identified as a female. And the parents came and asked about feminizing hormones like estrogen, and when was the appropriate time for that. And she was now in middle school, and her peers had already started to have some breast development and go through puberty. And so that was at that point we really sat down to really help her understand, help the parents understand what were all the risks and benefits of starting estrogen therapy. And after making sure she understood, the parents understood, she met with a psychiatrist, a psychologist, then we decided to proceed with estrogen therapy. And what we found is that anxiety that I described actually changed significantly. Becky was able to actually perform in musicals at our school and really engage in who she was authentically. And so as time went on, we really saw her develop. And it wasn't until she started to transition into college that she decided to have surgery. And so she was well past 18 years old when she decided to have surgery. And she had a wonderful response. I've seen the reverse happen. a few years ago, I lost my first patient as a result because they could not access surgery. They could not access gender affirming care. And so we know the evidence around the high rates of suicidality, the high rates of depression, and the high poor outcomes when we deny people with access to gender affirming care. And so I think to answer your question is the process I've laid out, Delegate Hill, is not a simple process. It takes time, it takes years, it takes meeting, it takes psychologists, psychiatrists, family meetings, parental support, youth support, all to make sure that everyone has the right information. Because we want to make sure we're doing good care for our patients and their families. We also know that if we don't do that, we know the outcomes when they don't happen, and it's harmful and can lead to suicidality.
Thank you very much. And again, I want to be cognizant of time, but I also want to make sure that we have the opportunity to have our questions answered while we have the expertise here in our subcommittee. So I have another question from one of the members, and then we'll open it up to additional stakeholders as time allows. Delegate Chisholm, go ahead.
Thank you, Madam Chair. You were talking about puberty blockers, and I think this is for Ms. Sanders, and pumping the brakes. But at some point, it's got to be irreversible, right? Is there a time frame? You go on puberty blockers for a month, then you go back to normal. But at some point, it's got to be irreversible because you have a male transitioning to a female, and if you were to take them off, I'm assuming they don't stay on puberty blockers forever. Is there some point where it's like, all right, you're a female now and you must stay there because of biological reasons? You've already made this transformation. Or is it 5 years down the road? Is it a year down the road? Is it 10 years down the road?
Delegate Chisholm, why don't you go ahead and I'll allow them to answer. I want to just be cognizant of time.
A person could be on puberty blockers for 10 years. When the puberty blockers are stopped, their natural puberty would return. This is true whether they've started gender affirming hormone therapy or they have not started gender affirming hormone therapy. If their body parts are still there and their brain is still intact, they would start going through their own puberty.
So if you're 13 and you do it for 10 years, at 23, you're going to go back into puberty?
Yes.
Okay. Madam Chair, this is a very important question. Can I follow up?
Absolutely.
When we talk about the suicide aspect of this, it's obviously very emotional. Everybody's concerned about it. Do we have any proof that after the surgery that suicides have actually declined? Because I'll be honest with you, I get a lot of conflicting information from different groups. So, and you don't have to answer. If Delegate Kaiser wants to send that report out, then to the committee, maybe be great for all of us to see what she has.
And Delegate Kaiser, are you able to share that report?
Yeah, there's many people on the call who could provide that data, but we will make sure that it gets to Delegate Chisholm and the rest of the subcommittee.
And this is a reminder to the body that this bill deals with the equity in providing gender affirming care. Because this is the same care that is still standard in many of our private insurers. So we'll get that data to you. Delegate Hutchinson.
Thank you, Madam Chair. I don't know if Tricia Roddy's on the call or somebody from Medicaid's on the call. And the question I have is that I had some email dialogue with her, but never direct conversation. And I'd asked the question, yeah, they're great, you're here. I'd asked you the question as to whether Medicaid currently pays for hormone therapy and puberty blockers. And could you give me the answer to that, what you gave me?
Yeah, so currently we do not pay for it for the younger population, only in special circumstances, but generally we do not for the younger population. We do for the 18 and older.
Thank you.
Once again, I want to be cognizant of time, but I think this is a really important conversation as we're talking about patient-centered, patient-first, family-centered care. So I do want to open this up to relevant stakeholders, but being cognizant of time, I'm going to go ahead and extend by 5 minutes, and hopefully we'll be able to catch up a little bit with the next bill. Dr. Pine, Dr. Sander, and then we'll go to Vince McAvoy and Riley Rashawn.
Medicaid does not cover surgery for minors, but puberty blockers are covered under current care. Minors, younger patients, minors are getting puberty blockers currently covered, as well as appropriate candidates for hormone therapy.
Thank you.
And,
Thank you.
I guess-
follow up, correctly.
Sorry, go ahead. Tricia, sorry.
I'll share the email that we had sent the other delegate so that the delegate can look at it.
Yes, because my information as well that I have, and I've seen patients with Medicaid, is that the Maryland Medicaid coverage is similar to the other 25 states that provide Medicaid services and cover gender affirming hormones under Medicaid services. That was as evidence in the information that was provided by Movement Advancement Project, and also some of the other literature that I think can be provided as well. So I'm just a little bit unclear as to the information that was just provided.
Thank you, Dr. Sanders.
So again,
Tricia, you'll share that. You'll share that
email
with the committee.
absolutely, so that everyone's looking at everything. And just to let you know, we have supported the bill. You do know that the administration has supported it, but we'll absolutely share what our current policy is.
Thank you very much. Dr. Sanders, was there more you wanted to add? All right.
No, I was just trying to respond to that. Thank you.
Thank you. I appreciate that. Mr. McAvoy.
Thank you so much. I hope that you can hear me okay. Can I get a thumbs up?
We can hear you.
Grateful. Thank you so much. I want to echo and sort of refer to issues that were brought up during committee where we are in 2-minute timing. So we can't get everything in. But I did mention in the bill hearing that puberty blockers and HGO's history of doing incremental steps show that this bill absolutely will, if not now, aim to capture children in HB 283. And in fact, there is no reference to children. So from the actual wording of it, this trend has particularly pedophilic nature. And this was affirmed by state legislature this week, where the Senate, I believe, Arkansas, Senate Judiciary voted a bill out of committee, preventing transgenders from being in the same bathroom with children. As for the so-called medical-oriented people, there's this push that has been in this discussion to say, if I'm a doctor, if I operate in this field or such and such, if that so-called makes me an expert, I want to disavow any of that. If you had a little girl come up to you,
Mr. McAvoy, do you have a question for the stakeholders?
I'm getting to it.
Okay, we are limited on time, so I appreciate that.
Thank you, Delegate. If a little girl came up to you and said, I want to be a mermaid, I want you to chop both my legs off, we would all our jaws would drop. This would be ridiculous. The only reason that this bill has been carried such far, and this is the question that I want answered, is the only thing that's carrying weight on this is that it's got a sexual nature to it. If somebody wanted to chop off their hand, we wouldn't allow that. If somebody wanted to put an anti-growth hormone on their foot, if such a thing existed, or their knee, we would never allow this. We wouldn't even discuss it, even if it was for sports. Not to mention
Mr.
up and
McAvoy,
down-
very, very respectfully, can you ask
Okay.
your question, please?
Yeah. So I want to make sure that everyone here and this has read the woman who worked in Missouri for this clinic, who disavows all this and says that the setups for this are spurious and they're not based on fact, repeatable fact. Why would this person go and put herself out as a whistleblower on February 10th, as a lesbian in St. Louis, Missouri, unless she was deeply concerned, as I am, ultimately about children? My extends to all people in Maryland.
Mr. McAvoy, can I ask
That's
if
the question.
there is a stakeholder who would like to respond?
Super, thank you.
Delegate Kaiser?
No comment necessary. He questions the credentials of doctors and isn't a doctor himself. We have doctors, we have research, we have the American Medical Association. We have every major medical association. And I think that's all we need. We don't just need somebody out there who makes up stories about people and provides spurious research when we have the documents and the research on our side.
Thank you. And thank you, Mr. McAvoy, for joining us today.
Thank you, Delegate. I sent the lawsuit there, so people can read it in chat.
I'm sorry. I have Riley Rashong, but also Sam Williamson. Did you want to go ahead and respond?
I think Delegate Kaiser responded beautifully. I have one very short comment that I'll hold until my turn comes up. Thank you.
Thank you so much. Riley, you had a question or a concern?
Yeah, I was actually wondering, I did a lot of research. I submitted a report in support of this bill. Maybe you've taken a look at it, but there are actually a couple studies I could cite to refer to Delegate Chisholm's questions about suicidality and mental health. Could I have your permission to just reference a couple of facts for the committee's benefit?
Absolutely. Thank you so much.
Sure. So probably 3 studies are going to be most relevant. There is a pretty wide body of literature on this. One of the higher quality studies that's going to be beneficial is a 2021 study done out of Harvard by Almazan and Kergolian. What they did was they had an N of about over 27,000 patients. And what they found was that transgender people who pursued at least one form of gender affirmative surgery were 42% less likely to experience psychological distress than the control group of those that wanted gender affirmative surgeries that had not undergone any such surgeries. That's probably the best study that you're going to have for general analysis of surgeries. There are 2 studies that are going to be more particular when we're talking about puberty blockers for youth. There's a 2020 study by Turbin et al. That analyzed survey data from 89 transgender adults who had access to puberty blockers during adolescence, and from more than 3,400 transgender adults who did not, and found that those who received puberty blocking hormone treatment had lower odds of lifetime suicidal ideation than those who wanted puberty blocking treatment but did not receive it, even after adjusting for demographic variables and level of family support. The last study I'll reference is a 2020 study by Vander Meesen et al. They compared transgender adolescents before and after receiving pubertal suppression and found, and they compared them with cisgender adolescents with similar ages from the general population. And they found that transgender adolescents showed poorer psychological distress before treatment. They weren't doing great before they received that treatment, but then showed similar or better psychological functioning compared with cisgender peers from the general population after beginning pubertal suppression. Those are just a handful. There's a decent other body of literature, but just I wanted to reference those since you asked the question.
Thank you. I really appreciate that. And we do have more bills to consider. So Sam, I'm going to give you the last bite of the apple. We're not voting on this bill today, but I want to make sure that everyone has the opportunity to have their questions answered or to formulate their questions for the future subcommittee and for the delegate, for the sponsor of the bill who is on this call and available for further discussions as well. Sam, go ahead.
Thank you so much. I know that a lot of the conversation has been focused on youth. I just wanted to remind everyone here that the bulk of this bill is for adults. I just didn't want to lose focus of that. This care really does save lives. I really appreciate all of you taking the time to listen today. Thank you.
Thank you very much. And I want to thank all of the stakeholders for being here to discuss this bill. And also thank all of the stakeholders here who are on the other bills we haven't gotten to yet. We will get to your bills, and I really appreciate your patience. This is really important work that we're doing, life-saving care that we want to make sure that we're carefully considering. So with that, we're going to wrap discussion on 726. On 283 for the moment. We're going to move to House Bill 626, which is animal testing and research, human relevant research funding and animal testing and research licensure. Erin, if you can walk us through the bill and the amendments.
Okay, you have a reprint of the bill that incorporates amendments that are offered by the bill sponsor, and these represent consensus amendments among the advocates and the research institutions involved in the bill. What remains in the bill as introduced would be the establishment of the Human Relevant Research Fund in TEDCO to promote state-funded research intended to develop human relevant alternatives to using non-human animals in testing and research through grants and loans. The bill requires TEDCO to establish the grant and loan program. And what changes in the bill, if you look in the reprint, if you go to page 6, the bill has established a licensure program, but that has been amended out to instead require a contribution. If you look on line 26 of page 6, it provides that on or after January 15th of each year, beginning in 2024, that each person that is located in the state and is required to submit an animal and plant health inspection service form 7023 pay to the department a contribution in the amount of $5,000 for up to 100 animals, $10,000 for more than 100 but not more than 500 animals, and $55,000 for more than 500 but not more than 5,000 animals, and $75,000 for more than 5,000 animals. The amount of the contribution to be paid is to be based on the total number of animals reported in column F on the most recently submitted animal and plant health inspection service form. The bill requires the secretary to distribute the funds that were paid to the research fund. So those funds would then be paid to the Human Research Fund to provide the grants to the entities. And there are individuals on the call that can explain what is in these forms.
Thank you. Let's go ahead and move the amendments, and then we'll open it up for discussion. Can I have a motion?
Move the amendments.
Second.
Second.
All right, amendments have been moved and seconded. Is there discussion? Are there questions for the stakeholders? Delegate Riley.
Yes, I'm off. Okay. Yes, thank you, Madam Chair. So in our hearings, I put down that the amendments were going to address the fiscal note and the penalty and the criminal status. So, and I had put down there, I thought the sponsor had said during the hearings that it just totally took out the amounts on page 7. So is this amendment doing that, or it's just saying it's a contribution, but they're still there?
Yeah, and I'm sorry, this is Eric. The institutions have agreed to that.
To what? Remove this? Make it
to the contributions.
Okay.
Are you talking about the contributions required based on how many animals that you have?
Correct. The amendment we just had.
Yes, and the institutions have agreed to that, and they're on the call.
Okay. But these amounts are still subject to to giving to TEDCO.
Yes.
Okay.
It goes into the fund.
Goes into the fund. All right. Thank you.
Do we have any other questions from the members? All right, let's go ahead and adopt the amendments. All in favor? They have been moved and seconded. All in favor, say aye.
Aye.
Any opposed? All right, on the bill as amended, can I have a motion?
Bill as amended.
Can I have a second?
Second.
All right, on the bill as amended, is there any discussion? All right, all in favor, say aye. Aye, this is. Any opposed? Go ahead and raise your hand. So I'm going to read them out to make sure we've got them. We've got Delegate Riley, Delegate Chisholm. All right. Thank you very much. All right, we are moving on to our very last bill, which is House Bill 1148. House Bill 1148 is the Behavioral Health Care Treatment and Access Behavioral Health Model for Maryland. We are going to be discussing this bill because it's quite comprehensive, and thank you to all the stakeholders who've been patiently waiting. It is 12:25. I do want to try and give you some time for lunch, but I think I can get you out by 12:40. So Erin, if you can talk us through the bill and then we'll talk about the amendments.
So the bill has four main parts. The bill establishes a commission on behavioral health care treatment and access. It creates a behavioral health care coordination value-based purchasing pilot program. It extends for 2 years provisions related to telehealth services, and it requires MDH to submit a Medicaid state plan amendment to establish certified community behavioral health clinics.
All right, and we had a lot of amendments that were requested. So we're going to talk through the various parts because I think we have consensus on 2 of the 4 parts of the bill. And Erin, correct me if I'm wrong, but I think there were some technical amendments that we were reviewing. And then we were going to talk about the composition of the commission. Now, as a reminder to all of our stakeholders, we will have work groups, and we have other work groups as necessary in the bill. This is a 4-year process. In talking with committee counsel, we are considering amending in a requirement to an internal review process to make sure that the commission is meeting the charge that they have. So let me first open it up to any of the members for questions before we hear from our stakeholders. Do we have any questions from the members? All right, I'm going to ask the first question then, because I know there was not consensus on the CCBHCs from the department, and I think we have Trisha Roddy. Yep, Trisha Roddy is still on this call. So Ms. Roddy, if you could speak to the concerns around the CCBHCs. As a reminder to our members, CCBHCs have a standalone bill in the Senate, but they are part of our comprehensive bill in the House. So Ms. Roddy, go ahead.
So Delegate Bagnall, I will let you know that there was a conversation last night on the Senate side, and we're still discussing, and we'll be reaching back out. But in general, I think what we've said in our testimony is that in order to get the federal dollars for CCBH enhanced match, you have to go through the plant, which in the next 5, and then after that, you'll be able to get the 65% match. We understand trying to start something a bit potentially for a group of the CCBHC. So we are discussing based on the conversation last night. We will be happy to get back to this committee as well.
That would be great. And just because I'm already doing what I tell people not to do, CCBHCs is short for Certified Community Behavioral Health Centers. So I'm trying not to speak in acronyms. And Lori Doyle, I see your hand up as well.
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland, and echoing what Ms. Roddy said, we did have a very good meeting yesterday on the Senate side on the CCBHC portion of the bill or the standalone bill. And I think from our perspective, we are all for the state going for the demonstration waiver that Ms. Roddy referred to that gives you some enhanced match. However, we think that the state should proceed with the state plan amendment like Kansas did, so that you are committed to this model. Obviously, there are things that can change at the federal level. It would actually give us a leg up for the planning grants and then the subsequent demonstration. So this is a step in the right direction. We also think it will, excuse me, will protect those grantees that currently have money to do CCBHCs and have started the groundwork, but are at risk of losing their grants if they're not extended. So there's a timing issue on all this too, but I appreciate Medicaid coming to the table, and we're going to continue to work with them. Thank you.
Thank you. Delegate Rosenberger, is this on the CCBHCs? Okay, go ahead.
Thank you, Madam Chair. I would just add that I had a conversation with Senator Cardin, and there is a interest in the federal delegation level to getting our state in to participate in the federal this program. They got language into one of the budget bills or one of the stimulus bills to specifically allow us to move forward. So I would just want to remind everyone of that, make everyone aware of that. So thank you, Madam Chair.
Thank you very much, and thank you for that context. Because I want to make sure that we have time to talk about the commission itself, I'm going to task myself with reaching back out to Tricia Roddy and Lori Doyle. Delegate Rosenberg, I will also include you in those conversations so that I can give a report back when we meet for the next subcommittee. So Tricia Roddy, Lori Doyle, Rory is on this call if we can set up a meeting so we can touch base and figure out where we are on the CCBHCs in terms of this bill. So now I want to, is that agreeable to all parties? I'm sorry, I looked away. All right, so we'll go ahead and do that work during the week. Now I want to turn to the composition of the commission because we do have stakeholders on this call that wanted to make their compelling arguments. I just want to remind you that we will have opportunities for work groups, but we want to make sure that we're creating a commission that is not so top heavy that that we can't get the work done because they're in the bill. They meet 3 times a year, but also that we're making sure that we've got the right mix of expertise at the table. We do have committee counsel on this call, sort of collating the information that we have from the subcommittee. So do I have questions or concerns or input from the stakeholders on this call who would like to be heard on this bill? I have Dan Rabbit, go ahead.
Sure. Thank you, Chair Bagnall, and hello, everyone. We definitely, here at Behavioral Health System Baltimore, we definitely understand there needs to be a limit to the number of individuals and organizations represented on the commission. We want that commission to be nimble and effective. But, I just want to make our case for not necessarily even Behavioral Health System Baltimore, but for some representation from local behavioral health authorities on the commission. LBHAs are really like a fundamental and unique and there is no similar institution or entity in our system. The majority of the funding and initiatives that we do at the state level, the Behavioral Health Administration pursues, is passed through to local behavioral health authorities who are responsible for contracting with all of the providers, ensuring accountability and licensure and high quality of all the providers, and submitting regular annual plans on what their counties or jurisdictions need in order to advance a more effective behavioral health care system. So just to kind of lift that up as an entity that we were surprised was left out of the commission, and that we think should be included and would be of great value. In our proposal, in our testimony, we proposed 2 LBHAs be added, one from a rural county, one from an urban county. But we understand that y'all are getting lots of requests, and if there are no additions to the commission, we of course will participate in whatever opportunities are made available to us, and I'm sure our LBHA partners feel the same. But just when I think about who are the top 30 some entities that are involved in our public behavioral health system. LBHAs are definitely near the top there. So just wanted to lift that up to everyone as you all are making these difficult decisions.
Thank you very much, Mr. Rabbit. I next have Laura Howell.
Thank you, Madam Chair. Laura Hallam here on behalf of the Developmental Disabilities Coalition today. And we are appreciative that a member of the coalition is included on the group. Again, we understand that there are a lot of people who want to be added. We had requested an amendment to add somebody with a developmental disability and a family member. I think even if it could be maybe one or the other, those amendments could be combined if possible. But the other piece that we requested was that there be a work group specifically looking at meeting the behavioral health needs of people with intellectual and developmental disabilities. We tend to get lost in these discussions, and it really is a significant need that creates issues in hospitals and emergency rooms, and really people struggle to have their needs met. So if there is some way to work with the subcommittee on an amendment that would make sure that developmental disabilities gets looked at very specifically, we would really appreciate it.
Thank you so much. Thank you for being here today. Ellen Weber. Oh, Ms. Weber, we can't hear you. I'm not sure. You're not muted, but we can't hear you.
Can you hear me now?
Yes.
Great, thank you. Apologies for that. In our testimony, we had endorsed amendments that NCADD Maryland had recommended for purposes of expanding the composition to include additional groups that focus more specifically on substance use disorders. And so there was a list of individuals included in that, including the Maryland Parity Coalition. In addition, though, to the composition, I wanted to know whether the chair was going to consider other amendments that had been proposed, including ours, that actually went to some of the substantive topics that the commission would focus on. So I didn't know where you were in that consideration, so wanted to raise that question.
I think the challenge, it looks like she might, and I appreciate that. I think we're trying to make sure that that was when I spoke to the review process. Because this is going to be a 4-year commission. I think we're trying to encapsulate that without being so prescriptive on what the commission is doing, because we know that this is like an onion. It's going to have layers, and we're going to learn things from year 1, which are going to inform year 2. We're going to learn things year 2, which are going to inform year 3. So I think we're taking it under advisement, but trying to figure out how to encapsulate it without making year 1 so comprehensive that we can't accomplish the goals that we're setting forth.
And I appreciate that. The really one request that I had was there was also some consideration about the purpose of the commission itself. And I know it's designed to develop all sorts of recommendations, but one of the other issues that consistently comes up in considering the vast number of activities that agencies are involved in is how to coordinate those activities. So I would put a request for that to be considered as a possible addition to what the purpose of this commission is. Working over a 4-year period, there'll be plenty of time to consider all sorts of recommendations. But among that, one should be looking at how these activities get coordinated.
Thank you, and I appreciate that. And we do have, as I said, we have committee counsel on, and we're both taking copious notes. So Michael Patty.
Great, thank you, Madam Chair. Just wanted to propose 2 amendments to add 2 different groups onto the commission. The first being licensed clinical professional counselors. There's over 4,500 licensed in the state currently. Obviously, these folks work directly for behavioral mental health services. So we just like to see an amendment added for them. And then also another amendment added for federally qualified health centers. These folks are around the state providing care into underserved areas. We just like to see them have a voice on the commission as well. So I know it's getting late, so I'll just leave my comments at that. We did submit written testimony for both groups as well.
Thank you. And we are reviewing all of the written testimonies. I appreciate that. Pam Casemeyer.
Case Mayor, and Michael Patty just stole one of my suggested amendments, which was also the federally qualified health centers, because they do sort of serve a unique role and have a unique perspective that we think would add to the conversation, or add to the work of the commission, or the commission's work quality. Just as Mr. Patty asked about the professional counselors, I think we noticed that the Psychology Association was included, and it isn't in any way to take away from their quality input as providers. But I think, as Mr. Patty also said, you've got other professional providers in that space, psychiatrists, you have clinical social workers. So how this committee works through that, we're a little concerned if there's only one professional organization represented on the commission, because the practices of each type of provider are somewhat different. And then I think we should look at the composition, and then the pediatric community believes there needs a little bit more focus on a pediatric provider on the commission, because obviously the pediatric component piece of this may be sort of analogous to the disability piece, can be very unique. And the implications and priorities and what they do. So we do appreciate you can't have 1 million people on this commission, but we did want to raise those additional members.
And while I've got you here, and again, I'm trying to make sure I'm not standing between my members and a little bit of lunch, but would the pediatric community see, similar to the IDD community, that this would be an appropriate work group focusing on pediatric needs that then would be reported to their member on the commission?
Yes, and in fact, they did raise, we were talking about commission membership, but they did raise the question of the work groups, and then fleshing out a little bit more what the work groups with respect to pediatrics would be doing. But yes, they did, ironically, yes, they did raise that as well in their discussion of the bill.
Okay, thank you so much. And Ms. Burgess, I'm sorry, I only have Ellie Burgess in the window. I apologize.
Thank you, Delegate Bagnall. I'm the interim deputy secretary for the Behavioral Health Administration. And so I certainly appreciate all the different stakeholders who want to participate in the commission. We did put in a letter of support. Our amendments respectfully would like for you and the committee to consider the BHAC, the Maryland Behavioral Health Advisory Council, as a source for this commission. We do the work that we're sure the commission wants to complete and have a vision for. That council consists of 28 in statute ex officio members. It consists of, and that's from the judiciary, the legislator. We have 13 members that are appointed by the Maryland Department of Health. We have 14 representatives that include a diverse range of individuals and consumers, professionals, et cetera. And so I'm certainly excited about the focus on behavioral health, but in ensuring that we can use our workforce as efficiently as possible, we would just respectfully want you to consider that amendment.
Thank you. Thank you very much. And Morgan Mills. Oh, sorry.
She said she used an abbreviation. What group is she talking about that we should consider?
The Maryland Behavioral Health Advisory Council. They advise BHA, and they meet every other month, and their work is certainly reflective of the work that the commission seems to envision occurring.
Yeah, I think you used the acronym BHAC, but yeah, the Behavioral Health Administration Council.
It's right. Thank you so much for asking me that question. I appreciate it.
Thank you, Delegate Hill, for the clarification. Morgan Mills.
Thank you so much, Chair Bagnall. Morgan Mills here today on behalf of NAMI. Just wanted to say, we're supportive of this bill, super glad to be involved, but just wanted to make sure that there is some clarity, just to echo what Ellen Weber with the LAC mentioned. There are other existing councils, such as the Behavioral Health Advisory Council that was mentioned. And so we just want to make sure that there isn't confusion amongst agencies that are already established. and just to ensure that collaboration, because ultimately we all have the same end goals. So I appreciate the time. Thank you.
Absolutely. Thank you so much. And I think we echo that. We want to make sure that we've got collaboration. Delegate Hill, I saw your hand go up.
Yes, thank you, Delegate Bagnall. So I know we're gonna be working on this for a while, but I just wanted to share with the subcommittee some notes that I made during the hearing. One is that we talk about the structure not wanting it to be too large, but if we, instead of looking at our public health commission that we just put in effect, if we look to something like the Attorney General Brian Frosch's Access to Justice Task Force, that had large numbers of stakeholders divided in a way that allowed for effective actualization. And we can have that discussion. Maybe council can get some information about how they were structured. I think it might be a better model for something like this. And then I also just wanted to offer that one of the things that the stakeholders here did not discuss, but I've heard is an issue, and this may be a vehicle for to address the issues of cultural training of staff who have to deal with the people with behavioral health issues, particularly in some areas like corrections, but in facilities that often, particularly when people come from different countries, we don't go through real cultural training with them like we do in other areas of health. And that can make a difference in whether or not clients and patients are receiving the kind of supports that they need. There may be a cultural issue that needs to be addressed. So I just wanted to share that for discussion and consideration.
Thank you very much. And I really appreciate that. We're obviously not voting the bill today, but we're going to regroup and come back with a report next week. Obviously, this is a priority bill, so we want to make sure that we have a bill that we can vote on and vote out of subcommittee and get to our members and get to the floor. So thank you all. I apologize for running over, but I think these were really, really important discussions. With that, we're going to go ahead and
can I do real quick?
Yes.
So
Yes,
just on the telehealth piece, there was amendments offered to add a study, and the Senate bill has passed with that study. So that could be something that maybe we could just agree on today. I know people might have concerns, but I think that study language would most likely get added to the telehealth piece.
So do you want us to take a vote on just a
no, you certainly don't need to vote on it. I just wanted, if there were people on the call that were concerned that wasn't
if there was
going to be addressed,
okay.
that
Gotcha.
I think it would most likely be added.
All right, thank you. I appreciate that. Thank you for bringing that up. And Delegate Rosenberg, I saw your hand.
That's a study extending the sunset, right? But with a study or no?
Yes, you still
Telehealth.
you'd still extend the sunset for 2 years.
Okay, fine. Thank you.
And that's studying the audio only and the audio visual. Thank you for bringing that up. I appreciate that.
Mm-hmm.
Thank you all so much for being here for this conversation. I'm gonna give you have 12 minutes to our members to grab something to eat and get to committee for bill hearings. Thank you so much. And with that, do we have a motion to adjourn?
So moved.
I'll second. Go get lunch. Thank you.